Good afternoon. My name is Donna Hayes, and I'm a student in the Chamberlain College of Nursing in the Master's Program. Today, we will be taking a high-level look at meaningful use and why it's important. This is a high-level overview meant for beginners, learning about electronic health records and meaningful use. References at the end of the presentation can be used to take a deeper look into meaningful use, its requirements, and incentive payments. The learning objectives for this presentation are to define meaningful use, also known as MU. This includes the purpose of meaningful use, describing at a high level the incentive payment and eligibility criteria, and looking at the difference between Meaningful Use 1 and Meaningful Use 2 criteria. The Electronic Health Record Incentive Program was launched as part of the American Recovery and Reinvestment Act of 2009. The HITECH Act is a section of the ARRA and establishes financial incentives for eligible providers who demonstrate the meaningful use of a certified electronic health record. Electronic medical record vendors have criteria that they have to meet, showing their system is certified to meet meaningful use requirements. Providers also have to do their part and use the system in a meaningful way. It is one thing to obtain a certified EHR. It is quite another to use that certified EHR to meet meaningful use criteria. Meaningful use criteria include CPOE, which is computerized provider order entry, electronic data exchange, clinical decision support, and patient access and engagement in their healthcare. In this picture, we take an apple and we use that apple in a meaningful way to make apple pie. The goal of health information technology is to promote free exchange of health information, protect privacy, improve patient safety, improve efficacy, and improve the overall quality of patient health care. Adopting and using an EHR can lead to incentive payments meant to encourage the adoption of electronic records, as well as help offset the cost of this new technology. Some of the goals of meaningful use are to improve quality, safety, efficiency, and reduce the disparities among patient populations. This can be done through computerized provider order entry, better known as CPOE. Part of CPOE and having providers enter information through the computer reduces the problems with reading handwriting, misinterpreting medications, and misinterpreting medication routes. Engaging patients and families in their health care should help reduce the risk of frequent readmissions as patients begin to take ownership of their own health care. Providers are encouraged to engage patients and families in their own health care. Another goal is to improve care coordination through clinical data exchange. Clinical data exchange among providers will help improve the quality and decrease costs by preventing redundancy in tests that are previously done. They can now be available quicker and with a larger range. Also, improving patient population and public health. This can be done through the electronic submission to immunization registries and other syndromic surveillance registries. And the last goal of meaningful use is to improve privacy and security of electronic health information. We are right in the middle of Meaningful Use Stage 1, and we're currently gearing up for Meaningful Use Stage 2. Providers are becoming more familiar with the measures, requirements, and making changes to their current workflows to accommodate meaningful use requirements. In the meantime, EMR vendors are currently improving their systems to meet Meaningful Use Stage 2 requirements. Meaningful use is planned for 3 stages. The first stage began in 2011, and the main focus was on data capture and sharing. The second phase, which is planned to start in 2014, is Meaningful Use 2. The goal of this phase is to improve patient care through clinical decision support and care coordination initiatives. Meaningful Use 3, which should begin in 2016 for providers, is focusing on improved patient outcomes. I've included a meaningful use timeline chart that shows the maximum payment that a provider would be eligible if they start on year 2011, 2012, 2013, and 2014. So the sooner you start applying for meaningful use, the more incentive money a provider is eligible for. Beginning in 2016, providers that are not participating in meaningful use will begin to receive a reduced reimbursement rate. Some providers are referring to this as a financial penalty for not participating. Who is eligible to receive these incentive payments? On top of everyone's mind, I'm sure, are nurses eligible? And the answer is yes. Medicaid does recognize nurse midwives and nurse practitioners as eligible providers. At this point, Medicare does not yet recognize nurses. Incentives under the Medicaid program can be as much as $63,000 over a 5-year period. Now, nurses are only eligible if their state is participating in the Meaningful Use program. Not all states' Medicaid departments are participating at this time. Now, it's interesting to note that the CMS incentive program is an all-or-nothing approach. So the measures must be reported on all patients, not just Medicare or Medicaid patients. And they are for all patients during the reporting period for the different measures. So the first year of a measure is a continuous 90-day period. All consecutive years, the entire year is included. So what this means is if you have a patient that is in the eligible criteria for reporting, all patients, whether they have Blue Cross Blue Shield, United Healthcare, self-pay, or their Medicare or Medicaid, must be reported. We're going to take a quick comparison between Meaningful Use Stage 1 and Meaningful Use Stage 2. Eligible providers in Stage 1 had to meet 15 core objectives and 5 out of a set of 10 of elective or what they call menu objectives for a total of 20. Stage 2, there's still 20 objectives, but now 17 are core, which are considered mandatory, and you have an option of picking 3 out of 6 particular menu objectives. These next 3 slides are boring. Sorry, there was nothing I could do to jazz this up any, but I'm giving you the brief overview of what 17 core objectives are. The first one is CPOE. You have to use CPOE, which remember is the computerized physician or provider order entry, for more than 60% of all medication and 30% of lab and 30% of radiology orders. So you have to enter these orders into the computer system, not handwrite them. E-prescribe. E-prescribe more than 50% of medications. So this would actually be e-prescribe more than 50% of eligible medication. At this point, a lot of states do not allow e-prescribed narcotics, so those would not be counted. But all other medications, instead of picking up that prescription pad, you need to enter them through the computer. Demographics. You have to record demographics for more than 80% of your patients. Demographics include age, race, date of birth, gender. There's other information as well. So there are references at the bottom of this presentation to get a deeper dive into exactly what is required. Vital signs. You have to record vital signs for more than 80%. Smoking status. You have to record the smoking status for more than 80% of patients over 13 years old. Interventions. You have to implement 5 clinical decision support interventions, including drug-to-drug and drug-to-allergy checks. An example of a clinical decision support intervention might be you have a patient who's over the age of 18 who has a diagnosis of hypertension. You should be getting an alert in your system to remind you to check that patient's blood pressure. Labs. You have to incorporate lab results in more than 50% of your patient population. The patient list. You have to be able to generate a patient list by a specific condition. So your staff needs to be able to run a report to tell you all of the patients that you have that have diabetes. That may be something that you want to use to do some quality initiatives with and take a look at that patient population and make sure that they're up to date with their lab. Preventative reminders. You have to use the electronic health record to identify, through probably a patient list, and provide reminders for preventative follow-up care for more than 10% of patients with 2 or more office visits in the last 2 years. This measure has changed a little bit. What they're saying by having 2 or more office visits within the last 2 years is this is establishing that this is a patient that you're currently following. And you need to provide a reminder. So if you have patients that are over the age of 50 that have not had a mammogram within the past 2 to 4 years, you may want to send those patients a reminder that they're due for a mammogram. So that's the type of preventative reminder. These are not appointment reminders. Continuing on with Stage 2, Eligible Provider Core Objectives. Number 10, patient access. You have to provide online access to patient health information to more than 50% of your patients, and more than 5% of your patients actually have to go in and look at it. So there are several things out there and several vendors that are creating these personal health records that are secure. There was a push to have this measure excluded because providers felt that they could not force their patients to go online and look at their own records. But the federal government is convinced that if we can get patients engaged in their own health care, that they'll take better care of themselves and have decreased hospital stays. So our job as providers is to go in and encourage our patients to access their health records and become involved in their health care. Visit summaries. Number 11. We have to provide office visit summaries for more than 50% of your office visits. So when your patients leave, they need to have a summary of what you did today, including the patient problem list and their medication list. Educational resources. You have to use the EHR to identify and provide educational resources for more than 10% of your patients. These educational resources need to be relevant to your patient. So you can't just give everybody a preventative flu vaccine handout. That's not going to work. This would be providing a new diabetic with educational materials that are generated from your electronic record on their diabetes or hypertension. Or if you gave somebody a flu vaccine, you want to give them some information on the flu vaccine that they received. Number 14 is prescription reconciliation. So you have to reconcile your medications at more than 50% of transitions of care. So what this would mean is if the patient goes to the hospital and comes back, the patient goes to home care, if the patient transitions to any kind of care, including, at this point, another provider, you have to reconcile that medication list. This particular measure, if you go and read the measure, is still a little bit fuzzy, and I'm sure some more clarification will be coming about before 2014 of exactly what is a transition of care. Number 15 is a summary of care. You have to provide a summary of care document for more than 50% of transitions of care and referrals, with 10% of those being sent electronically and at least one sent to a recipient with a different EHR than the one that you have. And again, how do you know what another doctor's office has? So they did add in here that you could successfully test this using CMS's test EHR. That does seem a little bit strange that I have to send electronic records to another doctor, and it only counts if he has a different electronic health record. So anyway, they're trying to get into sending records electronically between caregivers. Number 16 is immunizations. You have to continue to send immunization data to immunization registries across the state. There are several different state immunization registries. At this point, not all states are participating, but they will have to be before Meaningful Use 2 in 2014 is effective. This goes back to your population health and your public health measures. Number 7, 17, security analysis. You have to conduct or review security analysis and incorporate in risk management processes to ensure that your patient's health information is protected. And these are the 17 core objectives that must be met. Along with the 17 core objectives that are required, there are 6 menu objectives or electives, and you have to select 3. So you have imaging results, where more than 20% of imaging results are accessible through a certified EHR technology. Family history, record the family health history for more than 20% of patients. Syndromic surveillance, so what this is successful ongoing transmission of syndromic surveillance data. So if you're doing, I know in Washington, D.C. and New York, there's a big push for elective HIV testing and sending to the public health agencies. This would be syndromic surveillance. Cancer registries, ongoing transmission to cancer registries, and then there are other specialties registries that you can be sending information to, and progress notes. Entering electronic progress note for more than 30% of unique patients. They're trying to get people away from dictating and free texting using the electronic medical records. If you didn't think all of the meaningful use criteria was bad enough, part of meaningful use criteria are submitting clinical quality measures as well. So clinical quality measures, what these are the national quality standards. So taking, for example, NQF 0013, and I believe there's 48 or 49 of these individual quality measures. Hypertension, this is blood pressure measurement. The percentage of patients that are over 18 years old that have a diagnosis of hypertension and that have been seen at least twice and have had their blood pressure recorded. So your certified EHR will have the ability to run these reports for you and collect this data out of your system if you use discrete data entry and not free text. So this is a classic example of why we need to use the electronic medical records and use the click buttons instead of dictating or using free text. If you free text in blood pressures, the system is not going to recognize that you took a blood pressure. If you don't use ICD-9 codes and diagnose the patient with an appropriate ICD-9 code for hypertension, the system's not going to recognize that this patient has hypertension. And the demographics as well. We have to be able to recognize that the patient is over 18 years old. So this is leading into using an electronic medical record in a meaningful way, which is actually using it as designed, using the click buttons, getting away from dictation, getting away from free text. For the most up-to-date resources for meaningful use, clinical quality indicators, or anything to do with health information technology, you always want to go to the CMS webpage. Take a look at cms.gov, and they should have all of the references that you need, and they do keep this site up to date. In summary, meaningful use is a provider behavior. The federal government has set out to encourage providers to adopt electronic health records and begin sharing data among each other to improve patient care. Adopting interoperable technology can be expensive and time-consuming. This is a new way of providing care. Instead of keeping patient information in a paper chart that's only accessible to one person at a time, we now have to not only share data, but enter and store data in a way that can be shared through a common interface. Along with improved communication between providers, meaningful use should cut down on duplicate test ordering because there was no awareness of the test to begin with, or the results can't be found. Patient engagement in their health care is also a new concept. Providers need to encourage patients to be involved in their care, seek out quality organizations, and follow up on chronic diseases, becoming part of the treatment plan. The federal government believes the more engaged the patients are in their health care, the more apt they are to follow recommendations and seek care early, thus avoiding hospital admission. I hope you all found this presentation a valuable experience, and the references are on the following slide.